I'm meeting today with Brian Coombs, a licensed psychotherapist, and I'm going to let him introduce what the subject is. And I know that many of you have been clamoring for something like this, so we're glad that he's agreed to come and meet with us today. And so before we begin, if you've seen a couple of our videos, you know I'm asking you to give us your name and your contact information for those that may want to contact you if they find what you discussed today resonates with them.
I appreciate it. My name is Brian Coombs. I am a clinical social worker and specialize in the treatment of obsessive compulsive disorders. I practice in Sugar House, Utah, and my cell number is 801-808-1267.
Now, when we found out about you, we were excited because we know that obsessive compulsive tendencies, disorders, and the difficulties it can cause in people's lives often come up or are exacerbated by divorce and child custody and family dysfunction. But sometimes people get confused and they think, oh, well, then you must be a specialist in the area of obsessive compulsive disorders in families. But that's, I mean, certainly you can help a family, but that's not all you do.
That's correct.
So why don't we talk a little bit about what somebody in your position can do for people generally, and then we'll try to narrow things down a little bit to obsessive compulsive tendencies and some of the problems that causes in family dysfunction. That sound good?
Yeah. Obsessive compulsive disorder is one of the most prevailing mental conditions in society. Anxiety disorders rank as the top mental condition in the United States. In fact, there's billions of dollars spent for the treatment of it, and one of the number one causes of disability in the United States.
And do I know correctly, because I think I've heard of this, but I don't know if it's fact or just legend, that it's increasing in the country as well? Or has it always been holding steady?
No, there's a prevalence, but I think, you can pretty much, I tell people, count every 40th person, you're going to see somebody that has OCD.
But it's not getting worse, because I know that they're saying a lot of mental disorders are on the rise because in an affluent society, there's, we pretty much got a lot of the hunger and stuff like that, but people are still unhappy even if they've got good jobs or they've got a lot of stuff. That's not the case then?
No, that's a good point. I think what my position, Eric, is to try to bring awareness to it that helps. I think it can very much get worse in societies like ours in Utah, because there's a predominant feeling here that things just kind of have to be, we live in a bubble, if you will. There's an air of perfectionism here, and that exacerbates anxiety and obsessive compulsive disorder and related disorders, if you will. So where I began is I created what's called the Obsessive Compulsive Foundation of Utah. And the goal there was to create awareness to mental health in general, and use the platform of O.C.D. to do so because it's a prevalent condition. Probably the most complex and misunderstood mental condition, in my opinion, out there. In fact, I call it a medical condition.
What makes it a medical condition? What is it? What's going on in people's heads or hearts?
That's a good question. I call it a medical condition because many of my clients fear to come and see somebody like me because they fear that they're crazy, that they're a step away from the funny farm. And oftentimes that's not the case at all. Like, as you mentioned, family law, definitely I have clients that are going through divorce and exacerbates it, but this disorder does not discriminate.
And what is it that makes them think that they're a step away from going to the mental institution? Is it because they do things that are so easily perceived as bizarre, or is that too simplistic a definition?
It's pretty simplistic, but it's true. I mean, I'll give you an example. To fit the criteria for the diagnosis, you have to have a couple things. One, intrusive thoughts, images, and urges. And two, perform what we call rituals or compulsions to neutralize or to alleviate the anxiety that often comes with accompanies in it the intrusive thoughts. For example, many clients individuals think of obsessive compulsive disorder as a cleaning disorder, a neat freak, or if you will. That's not the case whatsoever. Most of my clients are very successful, professional individuals that have families that are very well ingrained in society and hold jobs. And that makes it even all the more distressing at times because we all have intrusive thoughts, all of us. You may be driving on the road and imagine, hitting somebody after you hit a pothole. Someone with OCD will do that, and then they'll circle back around and check, or get out of their car and look for blood. They'll look for broken parts in the car. They'll do something like that, and they start to feel like they're losing their mind, and they convince themselves that there's maybe a bigger disorder than what really exists.
So for the people that we stereotypically think about who are always washing their hands,
That's correct.
what are they thinking about? Germs? Or are they thinking about, if I wash my hands, then my grandma won't get sick?
That's a great
Or,
point.
you know what I mean?
Oftentimes both, or one or the other. I mean, it's not all about germs. Again, achieving a feeling of just right. So somebody without OCD will recognize that they're washing their hands excessively. And when I said medical condition, there's parts of the brain that will allow somebody without OCD to recognize the stop loss and be done with their hand washing. Somebody that has OCD, those parts of the brain are overreactive and exacerbate that feeling, so it's hard to stop until they feel just right. And so it may be about germs, maybe about dust, or, interesting you bring that up, many of my clients perform rituals of compulsions, as I said, neutralize, so in order that something bad doesn't happen to themselves, a loved one, or someone else they're associated with. And so they perform those type of rituals.
I knew a little girl that if she ever saw closet doors open, she would close them because she thought that if she did that, God would prevent her from getting sick.
Sure.
And you're thinking, and it's like, well, what, do you think there's germs behind the door? No, it had nothing to, there was no causal connection, but somehow she said, I just felt like if I always close somebody left it ajar, like to get something out of the closet, she felt she had to go and close that door.
Sure. And that may or may not be OCD. That's very common. That's an intrusive thought. Imagine now, and not invalidating the story that you just told.
And I don't know what that means.
Imagine being a 45-year-old male or female that is afraid to open or shut their closet door because of something similar, and be a CEO of a company, or a religious leader, or somebody that's known in the community, and they have those type of fears, and they're performing rituals, and it distracts from their day and does many things that would, to you and I, maybe seem irrational.
And are they aware that they're doing something
Absolutely.
that people see as weird, or do they go, well, you may disagree with me, but
Oftentimes, and
but I have my reasons.
there's a qualification in the diagnosis of poor insight, fair insight, and most of my clients deserve an Academy Award, and I tell them that because they, as said, many of them are very functional in society, but they bank their anxiety, and it comes out, whether at home, in marriage, relationships with others, and so it creates a vacuum, if you will, and somehow that anxiety is going to come out. And so they're very much aware, and that anxiety just builds and builds and builds. It's very sad, actually.
Let me ask this then, before I lose my train of thought. Let's talk about how it's diagnosed, and then let's talk about how it's treated. Now I'm going to work backward. Is it treated in a way, and this is a thought that my guess is it's not true, but this is something I think maybe others are thinking too. Is the treatment ways for me to fool others into not noticing what's wrong with me? And I choose my words carefully. In other words, okay, I'm still crazy. I'm still just a step away from the funny farm. But you're going to help me so that I can look more normal and people won't think I'm weird.
Sure.
Yeah, and my guess is the answer is no, but I'm sure there's a lot of people saying, look, I can never imagine getting free of this. And my guess is also, yeah, you may never get free of that, like a lot of mental illness. I think it's interesting. It seems to me that people are starting to see, I will always suffer from depression. The question is, will I be able to manage it better? So let's talk about diagnosis. How does somebody get diagnosed? And then once they have been properly diagnosed, how does treatment work?
Let me first clarify what you're saying about I'm still crazy, and I'm not talking
because I'm exaggerating to
sure.
make my point.
The reality is my clients feel like, it's a very disheartening feeling to know that you're doing something that seems irrational. But when you're caught up with such high anxiety, and there's two different diagnoses there. Anxiety and OCD, obsessive compulsive disorder, are two, they're related, but oftentimes used interchangeably erroneously. Anxiety can be a precipitator for obsessive compulsive behaviors, just as obsessive compulsive behaviors create anxiety. And so the treatment, my clients are not crazy. My job is to help them understand that, and what you mentioned, Eric, is would be a compulsion, to give the air of that nothing's wrong and we're just gonna fool others. And that causes more anxiety. So the treatment, the real gold standard, they call it, is what's called exposure and response prevention therapy. It's an element of cognitive behavior therapy, but exposure and response prevention therapy, literally, instead of going around, as you described, the fears, and let me be clear, it's a thought of germs, it's a thought of harming somebody, it's a thought of being homosexual. Those are some of the main topics related to obsessive compulsive intrusive thoughts. Instead of going around, we go through them. So we would take somebody, for instance, that has a compulsion to harm themselves or somebody that they're dear to. I mean, imagine, again, being a married spouse, and this is coming to your profession as an attorney. I surmise that you've seen many cases of mental illness and that led maybe to divorce. I'm quick to respond to my clients and help their loved ones recognize that it's a true medical condition. And those neural pathways have been altered in the brain over decades of extreme anxiety and stress, almost like a muscle will build on your arm if you lift weights.
Wow, see, now that makes me feel, that just sent a chill through me, because I'm thinking, ooh, knowing that I was complicit in, I'm the one that built up those pathways. If only I would have just stopped when I was young.
Sure.
You know what I mean? But you can't beat yourself up over it.
You can't. But the good news is there's something you can do about it. And it's important for things like this, what you're doing to create awareness, to help others recognize that it can be managed, it can be dealt with. Explain again, imagine being a spouse of someone that their fears that they're chopping carrots up and they feel like maybe because they have a knife in their hand, they have an intrusive thought that they could stab their spouse. It's very common, actually, a wildly intrusive thought. And so they'll go to great extremes to remove all knives from the home. They won't cut up carrots. The number one compulsion there is avoidance, to avoid. And every time we avoid something, an intrusive thought, it's going to exacerbate that thought more and more and more. And the brain picks up on it, the structure of the brain, and will immediately, for the next time, this is what needs to happen. So what we help our clients do is recognize that maybe holding the knife in front of their spouse, and oftentimes they don't have to even explain to their wife what they're doing to their husband, but instead of avoiding, actually staying the course, the anxiety is going to go up, therefore the name exposure. Response prevention then is to eliminate the response that they're normally doing by getting rid of the knives, not cutting up carrots. We actually allow the response to go up, and we discontinue the neutralizing ritual, and therefore the brain will calm itself down naturally. And
because it will see that you managed to cut up a carrot and no one died.
It's habituating fear. Similarly, as you ease into a swimming pool that's cold, you jump into a pool. Oh my gosh, it's freezing cold. My wife does that every time we go to a pool. She touches her feet. But as you ease into the water, your brain starts to acclimate to it doesn't get warmer, but your brain allows itself to calm down. But you have to expose yourself over time. And so it takes a lot of real loving patience, both on the behalf of the sufferer and the family, the loved one. And because what's hardest probably for me oftentimes, because my clients are so successful and energetic, is helping them recognize that this is a true medical condition. You and I see people on the street on a wheelchair or crutches, we can visually see that something's wrong. When somebody's very active in their community or church or family and they're suffering silently, they will pretend, like you mentioned, they'll fool others. That's so difficult. And so it's very hard for me as a clinician to convince my clients that there is a real medical condition there that can be reversed. And once that trust is formed, progress will be made. It's all subjective. It's individualistic. Not everybody's the same.
When you talk about their feeling, in other words, they feel like hypocrites. Is that a big part of it? Like, I'm so afraid I'm a minister who's afraid I'm gonna stab my wife. I don't deserve to be a minister when I have murderous thoughts. But I'm also really prone to serve people and help people. Is that what you're talking about? Where it's
Sure.
like, and is it, I know it may not only be, but is it just a sense of, I'm such a hypocrite, I'm such a bad person, I'm living a lie, and then you're helping them to say, look, you have a medical condition. You might not be as good a pastor if you were in a wheelchair as if you could walk, but that doesn't mean you can't be a pastor. You're the wheelchair-bound pastor. You will maybe send people over to people's homes where others could walk over there and help with moving or stuff like that, but you can still help people love you you have a way with words, you're an eloquent person, you're very caring, you can still hold a baby and rock it to sleep. Is that kind of what you're talking about?
In a way, I mean, what the feeling, the sentiment they have isn't not so much hypocrite, they feel like a fraud. And let me be.
Could you explain how somebody feels like a fraud, whether it be the murderous tendency, or the intrusive thoughts, not the tendencies, or we could talk about homosexuality, for example, or we could talk, can we give me an example of how they feel like frauds and
Okay,
why?
I'll use my example.
Okay.
When I was young man, I was diagnosed with obsessive compulsive disorder. And I was a checker, that they call it. I was intrusive thoughts where the stove's on, the house had been burned down, and then it exacerbated over time, and it kind of went away, which is fairly common. The median age for the diagnosis for males is 19 and a half years. Right around that same time, mine went through the roof, my anxiety and O.C.D. And about a year and a half after that going through the roof, I had convinced myself that I was homosexual. Okay. And I did not know at the time that I had obsessive compulsive disorder. And so all the while I'm having a girlfriend, in fact, even a newly married young man, feeling like maybe I shouldn't be married. Maybe I shouldn't be a father at the point because maybe I'm truly gay. That's an extreme example, but it's very common actually. Okay. And so you would tend to pattern your, you would test yourself with certain things and question. It's very time consuming, and there's a lot of struggle there. And so you can imagine the complexity there, feeling like a fraud. You're with somebody, you're constantly.
Couldn't really fully commit to either life because you weren't sure which side you were on, so you couldn't, like, maybe I'm not the best husband, father kind of thing, or maybe I'm repressing my true self, that sort of stuff.
Let me explain. It's not so much choosing a life because it's a thought of being homosexual.
Yeah, that's what I mean.
Yeah.
So where does the fraud come in? Where does this?
Because let me give you a great example. It's not uncommon for me to hear clients say that they were with their girlfriend and they didn't feel like they were turned on, for example, if they were intimate, and that could potentially mean or solidify the idea that they were actually homosexual. But yeah, there's a lot of factors that go into that, and so anxiety plays a role in that, and so people are we become very when you suffer from O.C.D, you become very vigilant, even hyper-vigilant to your, what we would call physiological responses in your body. And so somebody's constantly looking and checking to make sure, and if you saw somebody on the street, like, well, you're a nice looking man, Eric. If I were to say that outside, of these walls, someone might think that was bizarre. Well, wait a minute. And then I would catch myself say, oh, why did I say that? That's not socially acceptable. But yet, all of us, every human being, we buy shoes because they look good on us. We find attraction. That's, and we're getting some of the nitty gritty, maybe deep here, but like I said, somebody without O.C.D could have that thought, Eric's a good looking man, not much to it. In fact, my father always used to do that, and I would tease him before, maybe to protect myself a little bit, until I recognized that, no, there's some good looking men out there and women. Yeah. And but someone that suffers from obsessive compulsive disorder would go to the extreme and try to attach meaning or significance to that thought, if that makes sense. Okay. So you can imagine being in a marriage, going back to what you do, and living with that and feeling like they're being a fraud in their marriage when in fact they're suffering potentially from obsessive compulsive disorder. The reality is I have homosexual clients, and there's a big difference between homosexuality and the thought of being homosexual. And
does it put a strain on the marriage,
of
typically?
Course. Yeah, and it doesn't. This topic's one that we just generated because of my example, but this could be even, I'm not going to say more benign, but...
Well, we talked about the intrusive thought of killing a spouse. We talked about the intrusive thought of, I may be homosexual in a heterosexual relationship. And I'm talking about strain in general.
Oh, yeah.
It's not only making your life miserable, the person who's suffering, but it's making those around you more miserable, not necessarily to the same degree, but they're also unhappy or uncomfortable.
Can be. There's a lot of loving spouses out there and it's ironic because a lot of the people that initially reach out to me are in fact the spouse that's not suffering from the disorder. And so that, I applaud that because that shows their commitment to their marriage. It can obviously go wildly different the other way because misdiagnosis, and that's the problem with the mental health community also, is there's a lot of uninformed treatment providers. And so that's why I chose to start the foundation and why I chose to specialize in treatment of obsessive compulsive disorders. For instance, I had a client the other day tell me they were in a clinician's office, and she told the person suffering from O.C.D, well, for every bad thought you have, think 2 positive thoughts. That's the worst thing you can do. For every bad thought you have, let's create 2 more compulsions on top of that. Unfortunately, that's very prevalent, not only here in Utah, but nationally, and that's not the treatment. You don't overlay, we have to lay down new memory, if you will, from the intrusive thought and the response that's neutralizing the anxiety. We have to go through it, and it's a very painful experience, but when done properly, very relieving and effective.
Maybe now's a good, so we talk about the, what would you call it, exposure and habituation. Is that all there is to it, or are there other approaches?
No,
to,
and I take an
talk
objective
about
approach,
those?
sure. I mean, acceptance and commitment therapy is one. I mean, again, to accept the disorder and commit to a life worth living, to accept a thought as a thought, to recognize, to be objective. It's very hard in the moment when you're so anxious to step back from the thought and recognize that what you're having or experiencing is a thought or a feeling. For example, I'm feeling stressed, and somebody would take that, well, then maybe I'm a bad person, or because I'm feeling stressed, I have to do this and this and that to make sure I feel better. We have to help people recognize that it's okay to feel a certain way, not suppress emotion. Like the famous psychologist Brene Brown would say, you cannot selectively suppress emotion by always trying to be happy. You're carrying an element of pain. You're never fully experiencing pure joy.
Unless you acknowledge the suffering, unless you acknowledge the presence of the pain.
Yes, and you say presence. It's hard to say present. The sufferer from obsessive compulsive disorder, his or her mind is constantly working in the future, and then also tearing through their past to find what we call reassurance, to validate their intrusive thought, find reassurance that it's not true. And so it's this given tug of war, if you will, 10 steps ahead of everybody else, and then ripping through. And then this involves some of the neurology. And as I explain that to my clients, they recognize how the brain works. They can see it live. And there's this huge awareness, and then all of a sudden they feel like they're understood and they're not crazy, and they can see how it works and they can work toward it. So it's, to your point, it's not all exposure. And that's something I'm very sensitive to, because most exposure therapy done, well, that's not probably fair, but
too much.
The failure is in the clinician's hands, meaning that it's done improperly, because it is a neglective approach. You have to assess for depression. Somebody has to be in the right state of mind to really effectively challenge their fears. And so all too often, I have clients that go to different treatment centers or places around the country even. They're widely known for their exposure expertise, but they don't, that's what they're known for. So the people pay thousands of dollars to go to these treatment centers to get exposure and response prevention therapy when they might not be able to handle it. I wouldn't push somebody out of a wheelchair and tell them to go run a marathon without first doing some physical therapy
and getting them to. Yeah.
It can backfire.
Yeah.
And so.
Yeah, because they might say, okay, you told me to get up and walk. I didn't.
Your thoughts. And so you have to recognize that's where the acceptance comes in. Everyone, again, back to the diagnosis, all human beings have intrusive, unwanted thoughts and images. When you take away the neutralization of that, the compulsions and rituals, you can see the disorder dissipate. It does not qualify anymore for the recognition of obsessive compulsive disorder. But learning to recognize your thought, and that involves a lot of humor. I mean, people are more successful dealing with people they like, and there has to be a firm level of trust. What's neat about my practice, because it's so scary to work with somebody that they don't know around these thoughts that they've been holding in for maybe even years and years and years from their spouses, loved ones, children, whomever.
Co-workers, whatever.
Yeah, I tell my clients initially, what's neat about this treatment is you don't even have to believe me. You don't even have to believe me, because all I want you to do is just try to do what I'm asking you to do, and the brain will start to work for itself. The brain is a malleable tool that can be altered through repetitious behavior, and so we have to be
a positive attitude might help, but even if you don't have any faith in it at all I'm asking you to do is try and see for yourself.
That's right. We're laying down new memory.
That's interesting. Before we finish, then, is there anything that you would like to share about the diagnosis and how one goes about being diagnosed?
It's a great question. I mean, it starts in, even pediatric, adolescent, it exists. And oftentimes, as parents, and I have 3 children, we see little idiosyncrasies that we would see in our children that maybe we think is a phase. As you start to see and tie that into, for example, high grades, high achieving, there's nothing wrong with that. But in the home, we have to be cautious on how we speak. Children are so aware of what's happening. They're so aware of language. When was the last time you learned a new word? It's been a while.
It's been a while.
You might hear something once a week.
Right.
Children are picking up on new words daily, dozens of words. They're watching action. So, for example, one time I did this with my little boy. I went in and picked the toilet seat up, but I did it with my foot. And that's pretty normal. I didn't want to touch the toilet seat. Who wants to touch a toilet seat? How many people?
Yeah.
My 4-year-old at the time came in and he said, "I did it, Daddy, I did it. I picked up the toilet seat with my foot." And I thought, oh hell, I screwed up, so I had to go in and show him, no, you put it with your hand. But to him, he didn't associate it with germs or dirty.
Right.
He associated with something I was doing. But that can develop into something if he's constantly in an environment. I tell my clients, this is about 50% genetics and 150% environment.
Okay.
So it's important to look at your environment internally and see, and to not necessarily be so rigid on certain rules, because the sufferer will emerge from that. It's very common to have multiple people in a family suffer from obsessive compulsive disorder. I say where there's one, there's generally many, unfortunately.
So the process of being diagnosed, they sit down in the long couch and tell them about your childhood, or what do they do? Do they take a test? Do they do a scantron?
That's a great
Do you hit their knees with a hammer, or what do you do?
No, there is a diagnostic tool. There is a test. There's several tests. There's a full assessment that you assess again for. You want to see if there's a little bit of background, and from the background you can see where, not where things began, but you can see patterns. And so you want to do a full assessment of what led them to the current distress. And oftentimes you can see patterns and pinpoint certain things. You don't have to exploit those, and they don't have to be regurgitated. I consider myself a solution-focused behavioral therapist. So once we've ascertained that there was anxiety and some obsessive compulsive behaviors, then we assess for depression and other what we call comorbid diagnosis. And at that point, then yes, there would be maybe a test, just a scale, if you will. But many times
written down that I go and I check a box.
You see these at the doctor's office. I mean, I use those, but generally it's very clear the diagnosis once the assessment's on property. You see that.
Okay.
The reason why I might use a scale in my practice is not necessarily for the diagnosis. Obviously, that's very helpful, but more to recognize progress. The tendency with very successful people that excel, it's very easy for them to minimize success. And so even the most benign change that isn't so benign can be glossed over. Something they've been doing for years is so repetitive.
Yeah, it just kind of crept up on me. I didn't even notice I was making the progress.
That's correct.
Something like that. Well, let's finish with this. What does it cost, and is this something that is covered by people's health plans?
Most health insurance plans, unfortunately, because of legislation changes and that, mental health is now more readily available to be treated under insurance. What changed it almost at the same time was deductibles. Mm-hmm. Deductibles are so high now with the family health plan that rarely is the cost gonna.
So they brought more stuff in under the guise of it's more inclusive, but it's still just as hard to get because we priced it out of reach.
Sure. And so what I tell my clients is, look, find somebody that fits the criteria for a real exposure behavioral therapist that understands the disorder, and that I tell all of my clients, and people say, Brian, you shoot yourself in the foot. It's worked for me. The most important part of any treatment for any disorder in my mind, mentally, would be the relationship. 75 to 80% of success would rest in the relationship between the client and therapist. If my clients feel like they're understood, they will do the things I ask them to do. That's the utmost. So that might cost a little bit more money than spending time and spend more time and more money with a clinician.
I was going to say it may cost more money up front, but you're also you're equipping yourself the best way possible.
You're going to see a lot more relief quicker.
And a couple other things. Now, you may have seen this on some of the other videos. Can this be done with cash for people that are afraid of there being a record?
That's a great point. Happens all the time. Yes, cash. Most clinicians will take cash, credit card, HSA cards. It's a great way to pay for it now because of the high deductibles.
And do you keep records that could be subpoenaed in the future or that could be dug up by one's political enemies or things like that?
The records have to be kept for legal purposes on our end, but they're hard to get at, and even in law, as you know. And so clinicians generally fight for their clients, and confidentiality is the utmost importance.
Okay. Thank you so much. What a great, I mean, you can see he's been doing this for a long time because you just kind of, it all came together in a cohesive whole. But there may be some other questions that people have or that they have led them to ask additional questions or want to know more. So before we end, one more time, give us your name and contact information for those that would like to get in touch with you.
Sure. My name is Brian Coombs, and my phone number is 801-808-1267. And I practice right here in Sugar House.
Thanks again.
You bet.